Good, good evening to you all, and welcome once again to UPSC Combined Medical Services Test and Discussion. And where I told in my last video that I will be discussing only the paper 2 because due to the shortage of time and due to the making a short video. So, and I will be discussing today entirely on paper 2, and then I will be making another video, part 5 of paper 1. So, just now I am starting the question on paper 2 only, and now please be borne in mind that will be discussing pure and pure paper 2, because I will be now not in view of discussing paper 1, due to, as I told you, that due to shortage of time and due to time limit, so that I can discuss more and more questions to you and you can be benefited. And as I told you earlier also, and at the last of my video, I will be again telling that if you have any doubt and if you have any query or of any particular question which have been coming or have been skipped from my mind, you can always contact in my WhatsApp group, which is in Dr. Rajiv Sir's group, or through individually also you can drop a message in my WhatsApp. Now I am starting the very first question today, again on paper 2. Now the question is somewhat like this. It is, I think, the question of surgery, general surgery. Now, surgical treatment for a first listen the question, and then I will be giving you 10 to 12 second time, and really you will be thinking, and I will be explaining you with the details and explanation. Now, surgical treatment for a 40-year-old lady. Now, listen the question carefully. Surgical treatment for a 40-year-old lady with a 3x3 papillary carcinoma, that is PTC, papillary thyroid carcinoma, with level 3 enlarged lymph node is. Okay. Now, surgical treatment for a 40-year-old lady with 3x3 papillary carcinoma thyroid with level 3 enlarged node is what? Now, the options, first you hear the options and then you think for the answer. Option A, total thyroidectomy with excision of the involved nodes. Then total thyroidectomy with radical neck dissection, which is RND. Then total thyroidectomy with functional neck dissection. And option D is total thyroidectomy with postoperative radioiodine ablation. So what will be the answer? So you think for at least take 10 seconds or 15 seconds, and in the meanwhile then I will be coming with the answer. Now I think you have come up to the answer. So I am repeating the question again, and then I will be telling you what is the answer. Surgical treatment for a 40-year-old lady with a 3x3 PTC with level 3. Now, is total thyroidectomy with excision of involved node or total thyroidectomy with radical neck, RND, Then C is total thyroidectomy with functional neck dissection, or option D, total thyroidectomy with postoperative radioiodine ablation. Now, the correct option for this actually is option C, which is total thyroidectomy and functional neck dissection. Now, just before proceeding to the explanation, just I want to tell the HPE of all the thyroid carcinomas. Mainly, there are PTCs, then follicular, medullary, anaplastic, and lymphoma. So, among those, the most common is PTC, which has been given the question. PTC is the most common histopathology of the thyroid cancer, and always associated with the childhood radiation exposure or first degree relative. Post incidence occurs with the incidence of 30 to 50 years. BRF mutation, and most common, high recurrence, and females are most exposed than male, and it is a multicentric. Now, as far as treatment is concerned, when it is a case of microcarcinoma, or it is less than 1 centimeter, then we can do lobectomy and hysterectomy. And when it is more than 1 centimeter, like here it is a 3 into 3 centimeter, so naturally we have to do a total thyroidectomy here, no option left. And with radical neck dissection, radical lymph node dissection, or functional neck dissection, and we have to add low dose thyroxine, which is not given, but here the option C, total thyroidectomy with functional neck dissection, will be correct, because neither A, which is total with the excision of involved node, will be applicable. Neither nor the total thyroidectomy with radical R&D also we can't do, because it is a big tumor. And option D, total thyroidectomy with postoperative radioiodine ablation, also we can't do. So the option left with us is option C, and so option C will be the answer. Now, we are coming to next question. Here also, just you pay attention, and then now, yeah. Now I'm giving you, I'm asking, now all these questions, which again I am telling it again and again. All the question which I am explaining it to you, all other question I am telling it to you, has been came at least 5 to 10 years ago, and they are high possibility that they will come again and again. Same question. There's very much chance, because as I told you in earlier videos also, because UPSC questions are always straightforward question. They don't ask any question indirectly, or they can try to confuse, because they only test you that whether you have right concepts or not. So that is the main aim of the UPSC examiners, and they are highly qualified examiners, and they only check that whether you know everything or not, whether you know each and every concept, each and every in all the 19 subjects. So now the next question, again in paper 2 only, because I will be not discussing today in the video paper 1. So now the question is, DVT, or deep vein thrombosis of the calf, is best managed by what? The first you hear the question and listen the option, and then you think for the answer. I will be giving you again 10-15 seconds. DVT of the calf is best managed by anticoagulant. B is thrombolysis. C is surgical venous thrombectomy, and D is active physiotherapy. So I am telling you the option: anticoagulant A, thrombolysis B, surgical venous thrombectomy C, and active physiotherapy D. So you think for the answer, and then I will be coming with the answer with explanation, mild explanation. Now for I think you have, it's a very easy question, and DVT of the calf is only managed by anticoagulant, because for the DVT we give anticoagulant. We don't do thrombolysis, because thrombolysis is out of question. And surgical venous thrombectomy also we don't do because the prognosis is very good, and active physiotherapy also it is not indicated in DVT. When the DVT has been set in, we actually give the anticoagulant. Preferably, we try to keep warfarin and dexaverin or fondaparinux, etc. We try to give, and it is not needed because if it is a very mild DVT, then very common anticoagulants, which is warfarin, checking the PT-INR, we give. So this is the question. This is also a very easy question, and now I am coming to the a very important question. This is also a very interesting question. A 25-year-old patient has 5 into 5 amoebic abscess in the right lobe of the liver. Just listen carefully. 25-year-old patient has 5 into 5 amoebic abscess in the right lobe of the liver, and he is febrile. That means febrile, and has a pain in the right hypochondrium. Now, in the RHR region, there is a pain. Now, what should be the primary management? Include what? What should be the primary management of this particular patient? Now, options are laparotomy and drainage. Option A. Option B is ultrasound guided aspiration. C is ultrasound guided placement of pigtail catheter. Or option D, administration of antibiotic and observation. Now, you think for this. Meanwhile, I will be giving you the another question and asking. Now, I think you have come up with your answer. So here actually the 25-year-old patient 5 into 5 amoebic abscess in the right lobe and febrile and has the pain in the right hypochondrium. So here the main we will not do any surgical correction here. We have to just administer antibiotics, and we will observe, we will wait and watch. So the mainstay again as of amoebic liver abscess is drug of choice is metronidazole, which is given 750 mg TDS. Generally 750 we can give TD for 10 days or 600 mg. 750 mg perhaps is now not available as far as my knowledge goes. So if you give 600 mg ER TDS also, that can also do, and aspiration should be done for diagnostic purpose only. And therapeutic aspiration indicated. Now, therapeutic aspiration, when it is indicated, when serology inconclusive of differential diagnosis in pyogenic liver abscess, a therapeutic trial of anti-amoebic drugs is deemed to be inappropriate, as in pregnancy. When there is a pregnancy, then there can be it will be inappropriate. The liver abscess is secondary. If mostly in very rare 20-30% the liver is secondary infected, then you have to do. Or fever and pain persist for more than 7 days. Now, if you are treating the patient and if it is observation and 7 days, 10 days has gone, now you have to do the therapeutic aspiration. And rupture is imminent with extremely large abscess, more than 10 centimeters is there, then, and especially pericardial rupture from the left lobe appears likely, like more than 5 centimeter. And if the age is more than 55 centimeter, predictive of the predictive for the need of the aspiration. More than 55, if it is age is high, then you have to go for the therapeutic aspiration, or else just plain you have to administer the antibiotic and you have to wait and watch. Now, my next question is, first, this is also a very important question, and I think this is a question from the community medicine part, paper 2 only. Now, the Horrocks apparatus is used to measure what? It's very easy question and straightforward. Now, Horrocks apparatus is used to measure option A. First, you listen the option, then I will be giving you the answer. Horrocks apparatus is used to measure free chlorine, option A, combined chlorine, option B, free and combined chlorine, option C, and chlorine demand, option D. So, just you think for the answer, and then I will be coming to the exact answer. Now, Horrocks apparatus is basically the option. Actually, the correct option is option D. Horrocks apparatus is used for determining the chlorine demand, and more appropriately, it is used to find out the dose of bleaching powder required for the disinfection of water. So, as easy as that. So, just to remember this, and it is not used for neither for free chlorine or combined chlorine or like this. So, the answer will be free chlorine demand. Now, my next question will be, now just a small numerical again from the question of PSM only, community medicine. Now if you want to write in a notebook, you can write, or just you can do easily, because if you know because these are formula based question. Now in this paper 2, always if they ask the question of PSM, they always I have seen around 20-25 years question from the last 25-30 years, that they have given only the formula based question. So here also it is a formula based, that is in a village of 5,000 population, 50% suffered from cholera and 10% died. Now 50% are suffering from cholera and 10% died. Now what will be the CFR or case fatality ratio? So in a village of 5,000, now the population of the village is 5,000, where 50% are suffering from has already suffered from cholera and 10 has died. So what will be the case fatality ratio? And remember, ratio is always as a percentage. Okay, so and the percentage is always as 100. So now the case fatality ratio, as the formula goes, you think for a formula and then you can easily find it out. Meanwhile, I'm seeing what the most frequent question to ask, and that I will be discussing you. Now, yeah, now the answer actually is 20%, because I have given you, as perhaps I have given you the option. I have not given the option. I thought to you calculate and you make out your own answer. So option is the option is 20%. 0.2, A was 0.2, B was 1%, C was 5%, D is 20%. So what is the formula for CFR? First you have to know the formula for CFR. The formula for CFR is total number of death due to particular disease divided by total number of cases due to the same disease. So total number of death due to particular disease here is particular disease, the death is only 10, because 10% person has died, and total number of case of the same disease case is 50. So 10 divided by 50 into 100, so it is 20%. Simple. And it is a this question was asked, I think, twice, as far as I can see. Now, this is the question also important. You can see treatment of choice for acute femoral artery embolism. Femoral artery embolism is actually very common in the case of the arterial occlusion. The emboli generally arises from the heart. So, just the question is very straightforward given. Treatment of choice for the acute femoral artery embolism is option A, heparin; B, warfarin; C is immediate embolectomy; and D, embolectomy after rest for few days. So just to think for the answer, and I'm thinking about the next question to give you. Now, actually, the question which I have asked, the correct option is I'm asking the question once. I'm repeating the question once again. Sorry. Treatment of choice for acute femoral artery embolism is heparin, followed by B warfarin, C immediate embolectomy, and D is embolectomy after a few days. And the option will be C, immediate embolectomy, because here acute arterial occlusion is mainly due to the embolia arises from the heart, and the most common site is actually the femoral. The femoral site is the most common, 34 to 35%, and then popliteal artery is there, and then the common iliac. And brachial also very less, and very less is aorta and the axillary or superficial femoral. So, and the common manifestation is pain, pallor, pulselessness, and persisting cold, paresthesia, paralysis. And diagnosis mainly clinical. And if time persists, then angiography is done after because 6 hours after the muscle necrosis starts. So mainly clinical. We can easily find it out. And the treatment is arterial embolectomy is the treatment of choice, done before 6 hours. And if it is suspected embolism, immediate anticoagulation with the heparin, 80 to 100 international unit per kg. Bolus followed by 10 to 15 units per kg infusion will prevent further arterial occlusion. But before 6 hours, if it is suspected, we can do arterial embolectomy, and then we can prophylaxis. We can give anticoagulation with heparin. So immediate, but here because treatment of choice, they are asking the treatment of choice. So here treatment of choice will be only and only immediate embolectomy. Now again a very important question, and again this question is always asked. Next question which I am asking you, I am giving for this question particularly, which I will be asking you right now, I will be giving you only just 10 seconds, because it's very easy question. I think most of you will do it only. So most common manifestations of Wilms tumor. Okay, you must be. I think whenever I told you, you know the answer. So just because this question is always repeated, and this question has been quite again repeated always. Option A, hematuria, B is abdominal mass, C is hypertension, and D is loss of weight. Now, I think you know the answer. Wilms tumor, the most common manifestation of Wilms tumor is what? Neither it is a hematuria, because hematuria also occurs, but it is not a common manifestation. Hypertension, very rare. Loss of weight, not precisely, but actually the most is, you can see the diagnosis is also clinical. You can see a large mass, a large abdominal mass, and there you can diagnose. Case of you can take a help of a radiologist, and they will diagnose it's a Wilms tumor. Now again, this is also a very easy question, and it's perhaps from the general surgery only. The surgical complication of typhoid fever include all of the following. Now, what are the complications of the typhoid fever? Surgical complications of the typhoid fever, because if recurrent typhoid is occurs to any patient, then surgical correction for the typhoid, surgical correction for to correct the typhoid occurs, or else there can be a malignancy also. Though I am not in my clinical scenario, I have seen one or two cases. So here the surgical complication of typhoid fever includes all of the following except option A, perforation peritonitis, option B, acute cholecystitis, C, splenic abscess, and D, acute pancreatitis. You think for the, I think it will be also very less. I will be giving you only 5 to 10 seconds, and then I will be coming up with the answer. Now, now the surgical complication of typhoid fever, surgical complication of typhoid includes all the following except. Now, here the complication of surgical complication of the typhoid fever is actually cholecystitis, acute cholecystitis can occur, because since you are trying to eliminate the gallbladder, so acute cholecystitis can occur. Splenic abscess can also occur there. Acute perforation peritonitis can also be one of the complication there. But pancreatitis is actually, acute pancreatitis is actually very rare. Acute pancreatitis does not occur due to it is not so common. The main common is actually bowel perforation, hemorrhage, osteomyelitis, and cholecystitis, and sometimes psychosis also, ataxia psychosis, myocarditis, nephritis, persistent gallbladder carriage. Urinary retention also can occur due to because they are the ureters are very closely. Pneumonia, thrombophlebitis, and splenic abscess, hepatitis, and the DIC are the hematological complication that can occur. But they are also rare. But the main complication are acute cholecystitis. Acute cholecystitis is more common, which we have seen in our residency times. Very common. Now, this is also a very important question. It is actually from the. It should be come in the paper, but nevertheless, it is from the community medicine only. And the question goes like this: which of the following drugs is not used for the chemoprophylaxis of malaria? Chemoprophylaxis of malaria, which drug we don't give? Chloroquine, proguanil, artesunate, and meloquine. So these are the four options. Option A, again I am giving option A chloroquine, B proguanil, C artesunate, and D is mefloquine. So you think for the answer, and then I will be coming up with the answer. Now, the correct answer for this is artesunate, because artesunate actually we give for fulminant malaria, okay, and for chemoprophylaxis of malaria we don't give artesunate. The main actually give which we the chemoprophylaxis of the malaria is actually chloroquine we can give, proguanil we can give, and mefloquine, and the dose 300 once a week, same day, or for 6 days a week. Proguanil we can give 200 mg once a day. Mefloquine also 250 once a week, and then on the same day each week. Doxycycline also another tetracycline group antibiotic, which you can give 100 mg capsule once a day. So artesunate is for reserved for other type of indication of another type of serious malaria, and it is not given as a chemoprophylaxis. Now, I'm discussing with you the last question, and in then my next video I will be coming with the only of paper 1. As I discussed with paper 2, now I will be discussing the paper 1. So in my next video I will be discussing with you the paper 1. Now the last question is very important again, and it has been also asked quite a long time in one way or other. A 47-year-old post-menopausal lady was on adjuvant hormonal treatment with tamoxifen for 3 years, okay, and he was given post-menopausal lady. Why it was given tamoxifen? It is not written. 3 years for. Oh, okay. It is given treatment with tamoxifen, because actually tamoxifen we give. It is a palliative treatment for metastatic CA breast. For 3 years, for it is written for carcinoma breast. She came to OPD with a history of passing blood clots per vagina, and she is probably suffering from what? Now, straightforward question once again, because tamoxifen actually is a palliative drug given, and is a good drug for the CA breast. And actually, you think for a while, then I am coming up with the answer. It's a very good and interesting question. Now here CS came to the OPD with the blood clots, and now we have to see here actually maybe the patient is suffering from the C endometrium, because actually drug induced C endometrium is also very common, and it is indicative of the endometrial biopsy. And if you continuously we do treatment with tamoxifen for a CA breast, for metastatic CA breast, there can be a chance, like if the patient present you with these symptoms like passing blood clots per vagina, and you have to do endometrial biopsy. You have to send the tissue for a histopathic examination, and there if you see that it is a case of C endometrium. So these are some of the questions which I have discussed. And last but not the least, as I told you in my beginning of the video only, if you have any doubt, you can ask me any question related to the UPSC paper 1, paper 2, combined medical services, and either in the Dr. Rajiv Search group or in my individually in my WhatsApp number also. Thanks a lot. And next video I will be coming soon. I will be discussing with you only with the paper 1. Thanks a lot.